And look, just before I welcome and introduce Nicholas, just a few words, probably preparatory. It's I imagine that some of what Nicholas is likely to say tonight could well be distressing to some people under some circumstances. So if you find yourself in that situation, we'd very much encourage you to seek support from those from whom you would normally do so. And again, the topic that Nicholas will be talking about tonight can sometimes generate different points of view. So if that happens, and if people were to make comments or ask questions, if we could just respect each other's points of view, even if it turns out we don't necessarily agree with them at various points through the rest of the evening. So if everyone's happy with that, we might move on. And it's my very great pleasure to welcome and introduce Professor Nicholas Proctor. I've known Nicholas for many years now, and I can assure you if you ever needed the services of a mental health nurse, he would be the kind of mental health nurse you'd actually want to get the services from. He has long now held a professorial position in mental health nursing. He's the chair of the Mental Health Nursing and a group and leader of the University of South Australia's Mental Health and Suicide Prevention Research Group. That group is designed as a communities of practice. The research group brings together mental health consumers, clinicians, policymakers, and academic faculty. Professor Proctor is currently Australia's national representative to the International Association for Suicide Prevention and is a member of the expert advisory group to the Office of the Prime Minister's National Suicide Prevention Advisor, National Suicide Prevention Taskforce. And Nick's speaking tonight to why compassion matters in mental health and suicide prevention. Thank you, Nick, and over to you.
Look, thank you so much for being here. I'm coming to you today from the traditional lands of the Kaurna people, the original custodians of the Adelaide Plains and Adelaide region. I recognise Kaurna elders, past, present and emerging, and I thank First Nations Australians, Aboriginal Australians, for all of the incredible work that's going on, helping us make more informed and compassionate progress with mental health and suicide prevention for Aboriginal people. But also I'd like to acknowledge lived and living experience of mental distress, lived and living experience of suicide-related distress, and the important roles that carers play in supporting people in critical moments of distress, critical moments of the suicide experience, and the wisdom technique that we can all learn from through lived and living experience. So they're important acknowledgements, and I don't say them lightly because they are really our compass coordinates when I begin to think about tonight's topic, which is why compassion matters in mental health and suicide prevention. And I'm sort of going to go and answer my question straight away, or what the proposal is, and go to the next slide and say why it does matter. And there's a reason why I'm going straight to this slide, and I'll explain that too. So compassion, I think of compassion as kindness with a deep awareness and a connection to the suffering of oneself and others, along with the desire and effort to relieve it. So here I'm channeling Dalai Lama, I'm channeling Christian Neff, a lot of people who have been writing and thinking deeply about compassion. So yes, it matters in mental health and suicide prevention. It matters in the lives of people in distress. And my argument, which I'm going to come to, is we really want to do that, and we want to advocate for that in health and human services, and probably across a range of scenarios and settings and contexts at the earliest opportunity, from the first contact in mental health crisis or after an episode of self-harm. A worker should aim to develop a collaborative relationship with the person entering into that conceptualization of distress, the drivers of distress, encouraging stories to be told and lives are revealed. Now, all of these words are carefully chosen, stories to be told and lives revealed, because I've recently read a story which I've found very inspiring. And I'm going to go back in time to tell you about that story. It's a story that was published back in 1838. This book is freely available on the internet, and it's one of the most compelling things I have read for a long time. It was published anonymously when it was first published by John Percival. John Percival, a military man, incarcerated, and I use that language of the time, in purpose-built facilities across Europe, moved several times, different facilities over several months. And it's, if you like, in modern terms, it's an autoethnography. I think of it as a story that's being told about what happened to John Percival in a so-called mental institution. And he tells the story in a really compelling and powerful way of how happened to him, how he was treated, how he felt, what he thought, what he wanted, what he didn't get, what he didn't want, and what he was looking for. And again, there's so many layers to this book, and the one that I want to focus on is the story, because we explain our actions through our stories. I'm going to come back to that. So John Percival, here's a quote from the book across a couple of pages, 53 and 54. I won't read it out. Hopefully you can read that okay. But, you know, it just goes to really a very powerful, awful, but importantly, probably the first time these sorts of experiences were documented back in 1838. I mentioned he was a military man, but he hadn't, in fact, seen any active service. He probably, as a 7-year-old child, was deeply traumatized because he witnessed his father being shot dead in the House of Parliament in the UK. His father was a parliamentarian, had tried to bring something in in London, and an angry storekeeper shot him dead in the foyer in the courtyard of the House of Commons. So probably that early childhood experience shaped him. That's what a lot of people would argue today. But you can see here in his words, and you know, he's telling the story of what happened to him, and he goes into a lot of detail, as I say, and he says that I'm afraid it's all true. So back then, you know, he was being treated really much like we see in the images up on the screen. This is another volume published in 1838, again, which talks about the lives of people, and the translation here, mental illness is considered in medical, hygienic and medico-legal reports, published in, again, 1838. So back then, we're talking about an era where things were extremely harsh and very few options, and certainly not an option to tell a story. So back then, this whole concept of unseen mind, people were seen as quote unquote wild animals that had lost their reason, removed from society, subjected to numerous tortures and treatments in this completely catastrophic mistaken belief that somehow people would be, you know, treated or cured by these sorts of ways of managing people. There was a shift. People moved towards only in their homes and cared for by family, adopted a more humane approach. And it's probably John Percival and his writing and going public back in that time. The book was published a couple of years later with him named on the cover. In fact, in 1840, there was a re-release with John Percival's name on there. So that it was able to kind of get that story out. But there were these sort of transitions to moral participation in life, preferably accompanied by, you know, empathetic people who would support us. If we flash forward in my field of nursing, you know, we have really great leaders who've inspired us to think more deeply and more compassionately in interpersonal relations. And I've got the image here of Hildegard Peplau, who really kind of opened up some of this therapeutic thinking. So we're flashing forward several decades now to how that has really taken us and given us some foundations of what we're trying to promote very consciously and thoughtfully in the modern day. And that interpersonal relationship. And John's writing back in 1838 talked about interpersonal relationships that are antithetical to what we want to see today. His writing actually takes us to the harshness of treatment, being treated, you know, by being bound, by being beaten, by being tortured in really cruel and inhumane ways. But of course, now we're trying to promote something very different. But there are still occasions where stories break through and circumstances are such that we are going back in time. And in my home state of South Australia, we had the Oakton Older Persons Mental Health Facility. People will be aware that now shut down, this Older Persons Mental Health Facility was investigated by the then chief psychiatrist and a small group of others, including myself, doing that very primary report into Oakton. And again, it was a day of shame. That report led to a Senate Select Inquiry, which led to an eventual Royal Commission into aged care. So this was the starting point for all of that. More recently, we've had stories which are, very catastrophic for a different set of reasons. And here we are in a very different epoch. We're now flash forward into the 2017, 2018 stories where people are being treated very harshly. And there is that absence of compassion. But again, we're seeing people needing to tell their story and getting stories out, which is so incredibly important. And more recently, in 2023, we've got stories of people being overwhelmed and the moral distress that goes with that for a good number of people. So we're laying out here something that is important in terms of the changing nature of distress and the storytelling of distress, but also we're telling a story here where health workers themselves are in fact struggling with old attitudes and old ways of doing things. This is a paper just from a few weeks ago, which talks about the attitudes and experiences of clinical and non-clinical services among individuals who self-harm or attempt suicide. So this is a systematic review, which is a high-level review of published studies where you extract data from those particular studies. In this case, there were 29 studies in the data extraction that met the inclusion criteria, and the inclusion criteria is built around the title of the paper, and particularly around negative experiences of service provision and perpetuating a cycle of self-harm and a cycle of trauma. And in this next slide, I can sort of summarize these key findings. So this review showed that people presenting to services here in recent times, this is a paper just published a few weeks ago, have more positive attitudes towards non-clinical services providing therapeutic contact. So so-called ED alternatives or ED safe spaces or suicide safe spaces potentially within the voluntary sector or the NGO sector rather than clinical services. And that's really marked by ED units and inpatient units. And, there hadn't been that shift that people were wanting. So the comparisons were made with data from 16 years ago, and there hasn't been that shift. And certainly stigmatizing attitudes is a feature of that. So you've got the way in which people are feeling and also the stigma that is coming through, feelings of being superficially rushed through processes and procedures and social assessments. But this is also re-traumatizing for a lot of people. And I'm now going to turn my attention to that intersection between how people are spoken to and what are some of the intersections with being re-triggered and re-traumatized. And in my area, I think I'm thinking and trying to teach our students more deeply about the impact of past trauma and becoming trauma-informed. And, particularly for trauma, which might be related to refugee trauma, or it might be related to adverse childhood experiences, or it might be related to other forms of trauma, more recent exposures of trauma, but really trying to open up these conversations and try to get a sense of, the person within the story and the way in which trauma's impact can be deeply personal, pervasive, and complex. So it can be traumatizing to go to an ED service and feel that you are impersonally processed, and what we need to do and bring into conscious play to be able to mitigate that. And the 4 R's of trauma-informed practice are sort of shaping that thinking. So this is really antithetical to the life of John Percival back in 1838, where we really want to bring into conscious play a greater understanding as practitioners, programs, and organizations and systems, ways in which we can realize the widespread impact of trauma, and try to understand trauma narratives, have a strength-based approach, which is what certainly we're teaching. A lot of nursing schools, a lot of health schools around Australia are teaching and trying to promote, recognising signs of distress and expressions of distress or idioms of distress for some people, responding by bringing all of these things across policies, procedures and practices, and certainly actively resisting re-traumatisation, whether that's in the ED or whether that's in the inpatient unit. And that's really given birth to this rise of, I think, suicide-safe spaces and ED alternatives that we're seeing in Medicare locals, but we're also seeing in the NGO sector, in Urgent Mental Health Care Centre, for example, in South Australia. So these things are incredibly important, and they really should be a mechanism to shape compassionate practice. And we've been talking to people about what matters to them in the emergency context. And there's a couple of papers that I've just picked for tonight. There are many other examples, and we've certainly talked to people more recently, but face-to-face and person-centered skills, what we've been really wanting to know is what is effective, what are people using, what are people promoting, and we want to get that message out there and promote that as much as we can. And the focus must be on connection, compassion and relational safety in mental health care. So coming out of this work, coming out of those publications, has been this really strong emphasis, if you like, around empathetic communication style, authentic, honest approaches. This is what we really want to promote because we think this creates storytelling for feelings to be received and lives revealed. So if we collapse down this data and we think about what people are asking for, what people find is comforting and helpful, offering practical assistance and support, power sharing relationships, working towards living a flourishing and meaningful life, all really combine very nicely. Trauma-informed thinking can help shape this, can bring this into reality at the point of care. We can bring it into reality, certainly, in the way that people are encouraged and engaged to be authentic. So this revised therapeutic framework and way of working around person-centered, trauma-informed principles, I think, are foundational for compassionate care. Humanising nursing care. So really, we're borrowing heavily from Hildegard Peplau, who I introduced you to a moment ago, to really borrow these concepts and bring them to the modern day as much as we can, particularly in crisis. And working towards those sustained, genuine human connections. And in trauma-informed practice and compassion and connection are central elements and enablers of storytelling. So these are stories to be revealed and lives told in a way that a person shapes and wants it to happen. And for a lot of workers, people that we're working with in the graduate program, but certainly in professional development, they really will have to make sensitive revisions about how and when to move in new ways. And for them, it's a shift in thinking whereby people actively lean in and listen in. So the idea is about promoting that leaning in and listening in, working to allow trust to be developed and maintained. And we took a lot of these ideas and brought them forward into some further training that we've participated in. So this is an image from some work that I've been doing prior to COVID, going backwards and forwards to the United States under the auspices of the Mayo Clinic. And it's the Aeshi philosophy of care. So you may have heard of the Aeshi philosophy. The Aeshi has its origins in the mountains in Switzerland, the Aeshi mountain landscapes, and then it moved to Colorado, Vail, Colorado in the US. And the meetings went on 10 occasions across the life of the program, and more recently auspiced by the Mayo Clinic. And one of those people who has really encouraged the use of storytelling and compassionate leaning in and listening in is Conrad Nichol, who's pictured here, and the person in the middle is Lisa Firestone. And what he kind of really promotes is this belief about engagement. And so, we've got this broad consensus now about so-called suicide risk scales being unsatisfactory. but there's a growing, renewed investment of trying to understand collaboration in suicide prevention. And what Conrad has been promoting, and a lot of people are picking up on, I think in a really positive way, and what we're seeing in some of the ED alternatives is putting the storyteller at the center stage as an expert. Talk about, in this case, the ASU philosophy was built around suicidality as we explain our actions through our stories. So there is a focus on the therapeutic alliance. There is a focus on understanding and conceptualization of drivers of suicidality, originating from this has come out of a reaction to the biomedical approach, and it's a really personal way of working. So leaning in and leaning in to understand the motivations and drivers in the case of suicide from the person's perspective, assuming that the person is the expert at suicidal thinking and behavior, empathizing and validating those thoughts and experiences is really what's being promoted, and certainly being promoted in lots of ways, and validating the valid. And some of this is super important because of the rapid intensification of suicide. So this is a paper that's just been released a few weeks ago as well, and it repeats what we have known and seen in inpatient context. It repeats that in a community context, primarily with veterans. And that's about the rapid intensification of suicide preceding suicidal behavior. And this is a group of people in primary care in a community context. And it's kind of explains this phenomena we sometimes might refer to as unplanned or so-called impulsive suicidal attempts or suicidal processes. So to be able to have storytelling, to be able to accommodate what we now know is a lot more fine-grained and fine-detailed information about suicidal processes and aspects of the suicidal mind, really takes us to better understand urges and safety planning, and compassion, safety, trust, choice, and collaboration. All of these things that have been discussed and considered to be so deeply impersonal and important. And they're built around why safety planning is now showing itself to be the most effective indicated suicide prevention intervention that's available. So effective in terms of the evidence that's available, and as well as helping people reconnect with reasons for living, and to be able to mitigate the onset and worsening of suicidal urges. So we're seeing a lot more of that, and compassion is becoming central to this process. And what are the key elements of what I'm talking about? Well, Stanley and Brown, who have been really the originators and the authors of safety planning, have really set the scene around that. And they have come from the ASU philosophy. So they are also people who attended many of those 10 meetings across the ASU program. And what I've done here is just enhanced some of these really key areas to highlight these touch points, particularly at the onset or worsening of suicidal thoughts or suicide-related distress or suicidal crisis. And identifying reasons for living and living a meaningful life and a life worth living, recognizing personal distress triggers, so that's bringing some of that trauma-informed thinking, contact and connection with family members and trusted others, compassion around leaning in and listening in have been really important elements of that. And we took some of our thinking and some of the new thinking around this from some of Craig Bryan's writing. So Craig Bryan, who was the author of the paper around rapid onset, rapid intensification of suicide, he really does discuss these things very nicely. I think this is a terrific volume. It really explains some of these concepts, particularly around reasons for living and compassionate ways of leaning in and listening in, helping the person make a life worth living. And I'm really, really pleased. It's a great read for a different set of reasons to what the life of John Percival might be about. We've had a look at safety planning, and we've had a look at how effective it is. Published that in a very good suicidology journal, Archives of Suicide Research. And that gives me the confidence to be able to say, why and how it's becoming a lot more valuable for the lives of people. It has its origins with veterans, has its origins with people who have been in trauma situations and had trauma exposure primarily, but now it's being used in a range of other settings as well. We've also taken some of these concepts and worked with people with lived in living experience of suicide in regional parts of South Australia. And so this is a very brief summary of a study from just a few years ago, published in Crisis Journal, which was really designed around trying to support people in country and rural South Australia through storytelling with lived and living experience of suicide-related distress, combining with safety planning on a one-day program. And there were some 248 people from across South Australia, different parts of regional and rural South Australia, who participated in that. And we put some evaluation science to it. So we put some instruments to try and understand the impact of this. And their findings that we came up with extended some international evidence. We hadn't seen it delivered in the way that we had done it because it's a co-designed process with lived and living experience. But this is the only graph I have to share with you, and it's a really straightforward message and it's a good story. So in terms of confidence when responding to a person in suicide-related distress, we saw at T2, which is the day of training, a shift at T3, which is at the end of training, but 4 to 6 months later, that held over time. So that's a really encouraging sign. So T1 is a few weeks before training, so that's like your baseline. But on the day of training here, T2, and at the end of training, T3, so at the end of the day. But what's going on 4 or 6 months later after training is completed? Well, we've seen that people are more confident. This is 248 people across regional and rural South Australia learning about compassionate and informed ways of responding to suicide-related distress, having a lived experience person, a teacher with lived and living experience of suicide, actually being their teacher, alongside research academics and people with learned experience, I suppose you could say. But that confidence holding, and we're really encouraged by that. We're also seeing another kind of big headline, particularly around compassion in suicide prevention. And this is something that South Australia and Tasmania both have written into their suicide prevention strategies. The most recent strategy is the Tasmanian strategy. It was published this year. The South Australian strategy is a little bit older, but fundamentally they mentioned this approach called Connecting with People, and more than 6,000 people across South Australia have been trained. There's a whole series of modules. So there's people in the community who have done this. And I think what it does is it brings compassion, a big dose of compassion, into conscious play in suicide and understanding critical moments of the suicide experience with safety planning, collaboration, storytelling, the things that I'm really making a point about for tonight's presentation. So people who are clinicians as well as community people who have participated in this across metro and country. In South Australia, I'm a licensed trainer. I'm not an owner of this company, but I'm certainly very happy to be a trainer in that approach. And I'm up here tonight with Peter Ilves, who's also delivering that. So this is part of the online training. But it also talks about mindful self-compassion. Yes, I've talked about the compassion that we want to promote and really identify as being critical and important for health and human service workers, first responders, a range of people who might be supporting people in distress. But there's also mindful self-compassion talked about in some of these modules, but certainly something that is worth mentioning tonight. And there are 3 interacting components. This comes from the work of Christian Neff. Self-kindness versus self-judgment. Going gently is another way of I think about that. A common sense of humanity versus isolation and sharing. Mindfulness versus over-identification is another area. And there's lots of resources and links about that. And someone who has been really promoting this very well, and I think has got a great way of explaining these concepts, would be John Kabat-Zinn. You may have heard of John. but he's a terrific person on podcasts and other things that he really communicates these things very well. They're available on Spotify. There are also YouTube videos of John explaining mindfulness-based stress reduction, self-compassion, lots of applications, not just for health and human service workers, but just living everyday life and getting through some of life's challenges in the immediate sense, but also over an extended period of time. So mindfulness-based meditation, self-compassion, another expression of that. So that's really my main sort of body of work. And to sum up, I'm really wanting to get a message of why I think compassionate systems, people, and purposes can come together. And this is really pretty much my last slide. About validating compassionate care and supporting it, are coming together in co-design, communities of practice type engagement, and we certainly promote that very heavily, and have done that for a long time, communities of practice approach. And everyone within the system, what we're messaging externally, trying to get out there for the next generation of health and human service workers, nurses in particular, is to be supportive and be kind and be gentle, and to lean in and listen and get that message really solidly out there to improve the lives of people in distress and their loved ones. That is absolutely the true north, and the care in which we can draw some of these ideas from our state and national policy settings. A couple of examples shared tonight, South Australia and Tasmania, but I'm sure there are other similar policy settings. In fact, I know in Queensland, the Queensland Commissioner, Ivan Furkovic, I spoke with him just last week on Friday. He's promoting this very heavily at the moment about trauma-informed practice and compassionate ways of working. But it's also what we can gain from within, and the capability of combining lived experience and research evidence. So in our case, we took it into country South Australia, and lived experience, research evidence, lived and living experience with learned experience coming together to create a better future. So it's future making, in a sense. Letting go of the past, and that will be confronting, but there needs to be confrontation. There needs to be a shift from letting go of old governance and problem-solving practices. But being open to self-critique, self-reflection, and self-assessment, I think it's really important in mental health and suicide prevention, in clinical services, to look in the mirror and look carefully at what you see and work out how and where you can move in new ways, how and why to move in new ways, and think about that as they're coming together. So that's my main sort of slide to summarize these kind of key messages. And I can't finish tonight without acknowledging some of the great people in my team, some of the people that I'm surrounded by, to be able to do some of this great thinking and great collaborative work. That's not everybody, of course, but that's a good number of people who have been part of our world to think about these things. So thank you very much. I hope, please contact me. We make our material as freely as accessible as we can. We try to do open access publishing as much as we can. So most of those papers that you've seen are available open access. Thank you very much.